So today's class will be on antepartum hemorrhage. So what is the meaning of antepartum hemorrhage and what are the different causes for bleeding during pregnancy, especially in the second and third trimester after the period of viability is called antepartum hemorrhage. So our agenda for today's class would be the introduction and definition of antepartum hemorrhage, what are the causes which attribute to antepartum hemorrhage, and in detail we'll be discussing about placenta previa and abruptio placenta, and we will discuss what we have to do when there is bleeding in the late pregnancy in an algorithm form, and final tips and takeaways. So, what do we mean by antepartum hemorrhage? So, it is bleeding from or into the genital tract after the period of viability till the birth of the baby or till second stage of labor. So, this is called as antepartum hemorrhage. So, it is bleeding into the genital tract or from the genital tract after the period of viability. So, we consider after 24 weeks of gestation and before the third stage of labor, that is after delivery of the baby until second stage. If there is bleeding during the pregnancy after the period of viability, it is defined as antepartum hemorrhage. So there are multiple causes for antepartum hemorrhage. So what are the main causes for antepartum hemorrhage? It is mainly the placental causes, the local genital causes, and other causes. So what are the placental side causes? The main causes of antepartum hemorrhage are placenta previa and abruptio placenta. And sometimes there is some marginal sinuses which are present in the membranes and they can also rupture and cause antepartum hemorrhage. So these are the placental causes for APH. And next, what are the local genital tract and other causes? So whenever there is excessive show, so if she's in labor and there is excessive show, we will not be able to differentiate whether it is actual abruption or placenta previa or it is just excessive show. So we have to diagnose and we have to be vigilant whether we have to do a vaginal examination or not. So until we have ruled out placenta previa, digital examination should never be performed. So always the rule is whenever the pregnant mother is coming with bleeding to your labor room, you have to never do a vaginal examination till you have ruled out placenta previa. So you can open her last scans and see the location of the placenta. And if the placenta is away from the internal os, and then you can do a perspeculum and pervaginal examination. Till then, you have to not do because it will exaggerate the situation if it is placenta previa. So, what are the other cervical causes? So, if there is any cervicitis, any cervical polyp, cervical ectropion, or rarely CA cervix. So, all these are local causes whenever there are erosions, ectropion, infection, polyp, or rarely cervical carcinoma. And sometimes if there is trauma due to sexual intercourse, so if there is any vaginal trauma or vaginal laceration, this might also cause APH in her pregnancies. And other rare causes are vulvovaginal varicosities and benign tumors or malignant tumors of the genital tract, especially the vulva and vagina and cervix, and genital infections where there is increased hyperemia. This might also cause antepartum hemorrhage. And lastly, sometimes we might get confused that there is APH when there is hematuria. So that is why we have to locally examine her and we have to ask her whether she notices bleeding only during passing urine or it is involuntary and it is seen all the time. So that's how you differentiate between hematuria and actual antepartum hemorrhage. And other important cause for antepartum hemorrhage is something called as vasa previa. So whenever these vessels are inside the placenta, it is normal. But when these placental vessels go and migrate to the membranes, it is called as vasa previa, and these membranes will be just overlying the internal os. So whenever there is spontaneous rupture of membranes or artificial rupture of membranes, this will cause torrential bleeding and it is nothing but the fetal bleeding. So the fetus will succumb as soon as there is acute episode of bleeding in case of vasoprevia. So that is why the antenatal diagnosis of vasoprevia is of very much importance. And if you diagnose antenatally, you can do an elective cesarean and you can escape from heavy bleeding. But if you have not diagnosed antenatally and immediately After the rupture of the membranes, if you notice there is acute bleeding, and if there is even fetal bradycardia, that is an ominous sign for cesarean section, and it is a pathognomonic feature for vasa previa. And in certain systemic disorders like von Willebrand disease, leukemia, also there might be antepartum hemorrhage, and sometimes it might be undetermined origin. When you have ruled out everything else and still you are not able to find the cause, it is called as undetermined origin. So these are the main causes for antepartum hemorrhage. What we have to remember? We have to remember that there are three types: placental causes, extraplacental causes, and systemic disorders. So out of which placenta previa and abruptio placenta are of major importance. So we have to know the definitions, whether it is spotting or bleeding, whether it is a major hemorrhage or a minor hemorrhage. So these definitions are given in GTG guideline. So there is a GTG guideline 37A for placenta previa and placenta accretus spectrum. So they have defined, if there is just staining or streaking or spotting of the blood, it is called as spotting. If there is less than 50 ml of blood loss, it is minor hemorrhage. If there is 50 ml to 1000 ml of blood loss, it is called as major hemorrhage, but there are no signs of clinical shock. If there is more than 1000 ml blood loss and there is signs of clinical shock, then it is called as massive hemorrhage. So we have to know the definitions of antepartum hemorrhage. So whether it's just spotting or straining, or whether it is a minor hemorrhage which is less than 50 ml, whether it's a major hemorrhage between 50 to 1000 ml, and whether there are no signs of clinical shock, and when there is massive hemorrhage, definitely there is signs of clinical shock and the blood loss is greater than 1000 ml. So today we'll be discussing in detail about placenta previa, abruptio placenta, and vasa previa. So what is placenta previa? So what is the definition of placenta previa? So whenever the placenta is situated in the lower uterine segment, then we call it as placenta previa. So whenever the placenta is normally situated partially or completely in the lower uterine segment, it is termed as placenta previa. So what is the meaning of previa? Previa means it is which comes first. So comes before or comes first. So that means the placenta is coming before the baby. So that is why it is called as placenta previa. So whenever the placenta is situated partially or completely in the lower uterine segment, we term it as placenta previa. So there are types of placenta previa. So there is type 1, type 2, type 3 and type 4. So what is type 1 placenta previa? It is a low-lying placenta where the placental edge does not reach the internal os, but it is in close proximity to it. So how much is close proximity? Within 2 centimeter from the internal os. So if it is within 2 centimeter from the internal os, then we call it as a low-lying placenta. And next is the marginal placenta, where the placental edge is touching the internal os, but it is not covering it. What is type 3? There is partial placenta previa, where the placenta is partially covering the internal os. But as the cervix dilates, it might go up. But what is complete placenta previa? When the entire placenta is sitting on the internal os like this. So whenever the entire placenta is sitting over the internal os, it is called as total placenta previa or central placenta previa or complete placenta previa. So it is covering the internal os even after the cervical dilatation. And 1, 2 and 3 are again divided into type A and type B placenta previa. So what is type A? Whenever there is placenta previa and it is predominantly located in the anterior wall. What is type B placenta previa? When the placenta is located on the posterior uterine wall. So what is dangerous placenta previa? There is something called as dangerous placenta previa. So whenever there is type 2, type B then it is called as a dangerous placenta previa. Why it is called dangerous? Because as the head comes down and engages, it will cause compression over the placenta and it might cause fetal distress or it might cause antepartum hemorrhage. And also it might cause delayed engagement of the presenting part. So that is why it is called as a dangerous placenta
Which one
previa.
is called dangerous type, ma'am? Type
2B, marginal placenta with posterior. Next, so in this picture, we are able to see the low-lying placenta where it is
yes.
not touching the internal os, but it is within 2 centimeter from the internal os. The marginal is just touching the internal os. Partial is it's covering the internal os, but it is not completely covering. Whereas total, it is totally covering the internal os. So even after the cervical dilatation, it is still covering the internal os. And there is something called as major placenta previa and minor placenta previa. So what is major placenta previa? Type this and this. So this is major placenta previa, whereas 1 and 2 are called as minor placenta previa. And there is some classification called as the Oppenheimer classification, where the transvaginal ultrasound is performed within 28 weeks to predict the risk of hemorrhage and cesarean section. So if the distance from the placental edge to the os is more than 2 centimeter, the prognosis of cesarean is not indicated. It is between 11 to 2 centimeter, that is 11 mm to 20 mm. Then there is low risk of bleeding and low risk of cesarean section, because after dilatation, the placenta might be withdrawn upwards. But if the placenta is within 1 centimeter from the internal os, there is high risk of bleeding and cesarean section. If the placenta is overlapping the internal os, then definitely we have to go for an elective cesarean section and we have to not delay it. So this is something called as Oppenheimer's classification based on the transvaginal ultrasound. Next, we have to understand what is the incidence of placenta previa and what are the risk factors and theories which are put forward for placenta previa and what is the etiopathogenesis behind it. So usually the incidence of placenta previa is 1 in 167 to 1 in 327. So it is around the 4.5 per or 4 to 5 per 1,000 pregnancies. So for 1,000 pregnancies, 4 or 5 will have placenta previa. But it is less common in twins less common in singletons when compared to twins. So in case of singletons, around in 1,000 women, only 2.8 to 3 women might have placenta previa. But this risk doubles in twin pregnancy because of the macro placenta or placentomegaly. So whenever in twins or whenever there is placentomegaly in conditions like GDM, twins and all these, there might be increase in the placental size. So whenever there is increase in placental size, it might go and cause and go and stay in the lower uterine segment. So that is why in singleton pregnancies, the amount of the incidence of placenta previa is slightly less when compared to the twin gestation. Next, we have to know what are the theories put forward for placental migration. So, Bhargavi, you know what is placental migration?
Yes, ma'am. First, initially, even if I don't know the exact definition, but initially, even if there is low-lying placenta, by 32 weeks, we expect the placenta to have migrated. It is not physical movement of the placenta per se, but because of expansion of the uterine tissue, the placenta is stretched and pulled apart from the low level. So beyond 32 weeks, it usually doesn't happen.
Yeah, good. So, what is placental migration? So usually after 16 weeks of gestation, if the placenta is in the lower uterine segment, we call it as placenta previa. So that is why we have to always mention the location of the placenta only during the anomaly scan. So you have to know there is no importance of low-lying placenta or placenta previa in the first trimester. So you cannot in the first trimester When you do a NT-NB scan and if the placental tissue is in the lower uterine segment, you don't call it as placenta previa. But during the anomaly scan, I have mentioned it multiple times. Three things are important. So fetal anomalies are important, the cervical length is important, and placental location is important. So in this, placental location should be mentioned. So it should be mentioned in relation with the internal os. So by 16 weeks, if the placenta is in the lower uterine segment, most of the time by 32 weeks, the placenta has the tendency to migrate upwards. So, as you told, there is no actual migration of the placenta, but because of these three reasons, the placenta is pushed or pulled upwards to the upper uterine segment. So, what are these theories which are put forward? So, one is because of the development of lower uterine segment. So, the lower uterine segment starts forming from as early as 12 weeks of gestation. So, this is the lower uterine segment is nothing but the isthmus which is present between the anatomical os and the histological os. So this isthmus will be converted into the lower uterine segment. So it is 0.5 centimeter around 12 weeks and it gradually increases to more than 10 centimeter at second stage of labor. So this expansion of the lower uterine segment pushes the placenta to the upper segment. So this is one of the theory which is explained for placental migration. And the second one is the placental free uterine wall grows preferentially when compared to the uterine wall which is attached to the placenta. So what happens if the placenta is attached to the lower uterine segment like this free wall of the upper uterine segments grows. So when this is growing, the placenta tends to shift above. So this is called as the placenta free uterine wall which is growing in preference to the placenta included lower uterine segment. And the last theory which is put forward is something called as the trophotropism. So what is trophotropism? That is the placenta grows towards the fundus or it grows towards the more vascular part of the uterus. So in the uterus, fundus is the most vascular part. So that is why the placenta tends to grow towards the uterus, so uterine fundus. So this is called as trophotropism. So this all these three helps in resolution of previa, and that is why by the end of 32 weeks, if you have seen the placenta migrated, then the chances by 32 weeks, the chances of placenta previa will decrease. But after 32 weeks, if still the placenta is still in the lower uterine segment, the chances of migration is very less. It doesn't tend to get migrated. So if it is around less than 28 weeks, if you have found the placenta previa at term will be just 4 to 5%, 28 weeks. So between 28 to 32 weeks, the chances of remaining of the placenta previa will be 50%. Even after 32 weeks, if the placenta is in the lower uterine segment, 90% of the time it persists to become previa only. The chances of migration is very less. And also, my placental migration is less likely in following conditions. What are the conditions where the placental migration is less likely? Whenever there is history of previous cesarean, whenever there is posterior placenta, whenever the placental edge is very thick, and whenever the lower edge is less than 2 centimeter from the internal os, and or if it is completely covering the os. So in these cases, the placental migration is less likely. So what is the incidence of placenta previa by term? If it is diagnosed less than 28 weeks, only 4 to 5% persist till term. If it is diagnosed between 28 to 32 weeks, 50% of the times it persists till term. If it is diagnosed after 32 weeks, 90% of the time it persists to remain as placenta previa. And the chances of placental migration is low when there is history of previous cesarean section, when there is a posterior placenta, when the placental edge is very thick, and the placenta is less than 2 centimeter and which is completely covering the internal os. So these are the different reasons when the placental migration is less likely. Now we have to understand what is the theory behind or what is the etiology or etiopathogenesis behind development of placenta previa. But there are no actual facts, but we have just some theories to tell. These are the separate these are the reasons why there is placenta previa, although there is no definitive theory. One is whenever there is a local abrasion. So whenever there is DNC or whenever there is cesarean section or whenever there is uterine scar. So these times the placenta tends to go and get attached to the area where there is endometrial injury. So this is called as local abrasion, which is one of the risk factor for the placenta to get implanted in the lower uterine segment. And sometimes they tell whenever there is a pregnancy from ART, that is assisted reproductive techniques, even then the chances of placenta previa is high. And also one of the etiological factor is multiparity. So what they describe in history is placenta usually like the embryo goes and sits in the area which is not implanted before, so it wants something new. It does not want to go and get implanted in the previous implantation site. So multiparity, what happens usually if there are multiple pregnancies, all the upper uterine segment would have been occupied in the prior pregnancy. So as the pregnancies advances, the chances of previa will be more. So this is also one of the etiological factor which has been described in theory in history. So these are the different etiopathogenesis for placenta previa, although it does not have any definitive theory. So I already told about incidence. Now we have to know what are the causes or risk factors for placenta previa. One of the very important risk factor is previous cesarean section. So I already told you whenever there is local abrasion or endometrial injury, the chances of the placenta implanting there or placenta getting attached there is more likely. So the odds ratio for one previous LSCS is 2.2. For two previous LSCS, it's 4.1. For three previous LSCS, it is as high as 22.4 is the odds ratio. So there is 22.4 times more chances of development of placenta previa if there are three or more cesarean sections. Next important risk factor is the previous history of placenta previa. So this increases the risk of placenta previa by 6 to 8 fold. And whenever there is, I told you, local endometrial injury. So when it occurs, when there is any previous uterine curettage. And also, if the maternal age is advanced, the chances of placenta previa is more than fourfold. And also, I told multiparity. So, the chance of multiparity with one previous child, the relative risk is 1.2. With two previous deliveries, the risk of placenta previa is 1.5. And also in multiple pregnancy, because of the enlargement or placenta megaly, the placenta tries and goes and encroaches into the lower uterine segment. And that is why the placenta previa is more high in twins. So it is the incidence of placenta previa is 40% more higher in twins when compared to singleton. And also living in high altitudes. So what happens in high altitudes? There is decreased oxygen saturation. So whenever there is decreased oxygen saturation, the placenta will enlarge itself to provide sufficient oxygenation. So that is why women living in high altitudes also have risk of placenta previa. And the chances of substance abuse, especially smoking and drug abuse, which also causes vasoconstriction and it causes hypoxia or hypoxemia at the level of the placenta, which might also be one of the causative factor. And I mentioned before, assisted reproductive technologies or techniques are also risk factors for placenta previa. Next, how will you diagnose? So there are some symptoms of placenta previa, some signs, and the gold standard investigation of choices on ultrasound. And on an ultrasound, we see for the placental localization. So in this picture, we can see this is the cervix and this is the placenta. So it is completely covering the internal os. So it is almost type 4, where it is completely covering the internal os. So what is the symptoms of placenta previa? So it is painless, causeless, unprovoked, recurrent episodes of APH. So whenever there is painless bleeding, you have to think of placenta previa because usually abruption is associated with pain and also there is tense and tender uterus. But in placenta previa, there is no pain. So it is painless, causeless, unprovoked bleeding and there is recurrent episodes of bleeding. And what is a Stalworthy sign? Do you know, Bhargavi? So whenever the fetal head or the presenting part is tried to get engaged, or when you put pressure over the lower uterine segment, there is the dipping of heart rate. So whenever the presenting part is grasped and trying to get engaged, that time there is hypoxia or there is pressure over the placenta, and it causes fetal bradycardia. So this is called as Talworthy sign, but this is obsolete. We don't go and do this because it might cause fetal distress. So Talworthy sign is obsolete, but you have to just remember that it is the pressure over the presenting part over the placenta might cause fetal bradycardia. And usually, this episode of painless, causeless bleeding will be 70 to 80%. It occurs before the onset of labor. So, why does it occur before the onset of labor? So, whenever in the last weeks of pregnancy or in labor, what happens? The lower uterine segment stretches. So, whenever the lower uterine segment stretches, the non elastic placenta is sheared off from the lower uterine segment. So, this shearing of the placenta from the lower uterine segment is results in bleeding, which is nothing but the antepartum hemorrhage. So usually 70 to 80% this APH is noted in the last weeks of pregnancy before the before the onset of labor. Sorry. So then during the onset of labor, due to the stretching of the lower uterine segment and due to the separation of the membranes, even then there might be separation of the placenta. So this occurs in 10 to 20% of the cases. But in 10% of the cases, until 36 weeks also, the patient will not have any episodes of antepartum hemorrhage. So she will be asymptomatic. So in such patients, you plan for an elective cesarean section between 36 to 37 weeks of gestation. So 10% are asymptomatic, 10 to 20% have APH during the onset of labor, and 70 to 80% have an episode of antepartum hemorrhage in the antenatal period. So whenever there is antepartum hemorrhage or whenever there is spotting, or these are called as warning hemorrhages. So whenever there is no acute heavy bleeding, there is just spotting or there is just some amount of bleeding, these are called as warning hemorrhages, and you have to be very vigilant because she might go into acute bleeding placenta previa, where you have to intervene immediately and go and do a cesarean section to save the life of the baby and the mother. So that is why we have to plan for an elective cesarean if we have diagnosed placenta previa. So how do you diagnose? Mainly by ultrasound examination. So you will localize the placenta, and if it is attached in the lower uterine segment, especially within 2 centimeter from the internal os, it is called as placenta previa. So the diagnosis accuracy for TVS is more than the TAS, because in TVS what happens, the probe is at close proximity to the cervix. So that is why you will understand whether there is actual placenta previa or not. Otherwise, in the TAS, usually you have to localize the placenta in a half-filled bladder. Otherwise, what will happen? You feel that the placenta is stretched, but still it is in the lower uterine segment if you see it in full bladder. That is why the diagnostic accuracy of trans abdominal ultrasound is slightly less. The sensitivity is around 75% and the false positive rate is around 23%. But whereas in the TVS, the sensitivity is about 87%, specificity is around 98.8%, and the positive predictive value is around 93.3%. So that is why the diagnostic accuracy of transvaginal ultrasound is always better than transabdominal ultrasound. That is why whenever you do an anomaly scan and you recognize that there is placenta previa, immediately you have to take a transvaginal probe and do and confirm your findings about placenta previa. So this is very important. Though you have seen via TAS, you have to confirm that there is placenta previa by TVS. And if the patient is asymptomatic, you have to repeat the scan at 32 weeks and see if the placenta has migrated or not. So this is clearly given in GTG that once you diagnose the placenta previa, in the anomaly scan, you have to again repeat the scan at 32 weeks of gestation. And if still it is in the lower segment, that it means it is placenta previa and there is very less chances for migration. So that is why we have to do a TVS scan at 32 weeks. And if at 32 weeks it's still persistent, then we have to do the scan at 36 weeks. And if there is still placenta previa, you will go for an elective cesarean after a course of antenatal corticosteroids. So always USG is always better than other investigations, but you can do an MRI, especially when you are suspecting something called as placenta accreta accreta spectrum. So whenever you're suspecting placenta accreta spectrum, it's always better you do an MRI. So what is placenta accreta syndrome? Whenever the placenta is not just getting attached, but it is penetrating into the myometrial wall. So usually between the endometrium and myometrium, there is something called as a Nitterbuch's layer. So this Nitterbuch's layer, whenever it is absent, so this time what happens? The chorionic villi tend to seep into or invaginate into the myometrium. So if it is just other end and you're not able to remove, it is called as accreta. If it is invaginating into the myometrium, it is called increta. If it is coming out of the serosa, it is called as percreta. So whenever there is placenta previa and there is anterior placenta previa, you have to always rule out placenta accreta syndrome. So because anterior placenta has a higher chances of going into placenta accreta spectrum, and especially if there is history of previous cesarean deliveries. So that is why you have to do an MRI to rule out PAS, that is placenta accreta syndrome. Before they used to tell they used to call it as morbidly adherent placenta, but now they no more use this word. Instead of that, they use placenta accreta spectrum. So I have already mentioned there is placental migration. So mainly due to the development of lower uterine segment, due to the development of fundus, and also due to the growth of the placenta towards the fundus, which is called as trophotropism. The normally situated placenta at 16 to 20 weeks of gestation, most of the times they go and migrate to the upper segment. So only 3 to 4% persist till term. So the migration when it is covering the os is just 0.1 mm per week, but if it is away from the os, it is 4.1 mm per week. So if as it is away from the os, the chances of migration is more. So the placental migration is less likely when there is posterior placenta, when the placental edge is thick, when the lower edge of the placenta is 2 centimeter within the internal os, when there is history of previous cesarean, and when there is completely covering the os. So in these cases, the placental migration is less likely. So this is a flow diagram. It is also from GTG, which tells how to diagnose and follow up a case of placenta previa. So whenever there is low-lying placenta that is within 2 centimeter from the internal os, or if there is placenta previa which is completely covering the os, on trans-abdominal ultrasound between 18 to 21 weeks, we have to consider TVS if there is posterior placenta or high BMI. And whenever there is history of previous cesarean, or if there is any history of previous or anterior placenta or history of placenta accreta spectrum, then we have to do an ultrasound scan for PAS. And if there are no signs of placenta accreta syndrome, then you will do an ultrasound between 32 weeks of gestation, because at 32 weeks, almost most of the placentas would have been migrated. But if there is still placenta previa, and there is asymptomatic placenta previa, we have to give a course of antenatal corticosteroids and repeat the scan at 36 weeks. So first scan, anomaly scan, second scan, 32 weeks, and the third scan at 36 weeks of gestation. And even at 36 weeks, if still there is persistent placenta previa, we have to plan for a cesarean between 36 to 37 weeks of gestation. So plan for a scheduled cesarean between 36 to 37 weeks of gestation. But if there is recurrent bleeding episodes, if it is asymptomatic, you can wait till 36 to 37. But if there is repeated bleeding episodes, then just give course of corticosteroids and deliver her by 34 to 36 weeks. You need not still wait. And if there is only low-lying placenta, you repeat the scan at 36 weeks. If still low-lying, you can take an individual decision. But if the placenta is already migrated and it is more than 2 centimeter from the os, there is no further ultrasound which is needed. And if the ultrasound scan shows the features of placenta accreta spectrum, then we have to refer to a specialist center for multidisciplinary management. So that is very important because placenta accreta syndrome might even cause maternal mortality. So it has to be managed in a tertiary health center or in a medical college setup where there are all intensivists, neonatologists, anesthetists, senior obstetricians, senior midwives, everyone are there. So in such center, you have to be dealing with placenta accreta spectrum. So in utero only, you have to send her to that center where management can be done. So what is the outcome and what are the complications which might occur? So usually maternal, there might be antepartum hemorrhage, there might be postpartum hemorrhage, there might be anemia because of repeated bleeding episodes, sometimes because of the bleeding and opening of the os, there might be ascending infection which might leads to in chorioamnionitis or sepsis, and in 10% of the cases there might be placenta accreta spectrum, and sometimes if there is acute heavy bleeding there might cause maternal mortality also. And because of repeated episodes of bleeding and because of decreased oxygen carrying capacity, the chances of RDS, prematurity, malpresentations because the placenta is in the lower uterine segment, and congenital malformations are also more common when the placenta is in the lower uterine segment. There might be abruption also. So there might be placenta previa along with abruption in 10% of the cases. And because of the chronic hypoxemia, there might be FGR. And because of the compression of the head over the cord, it might also cause cord compression or fetal distress. So these are the maternal and perinatal complications. 1 second, Bhargavi.
Yes, ma'am.
Yeah. Now, how do we manage a case of placenta previa? Should we immediately deliver her or should we manage her expectantly? So, the key management parts are two things. So, when you have what type of bleeding is there? So, whenever if there is severe bleeding or there is any warning hemorrhages. So, what will you do if there is severe bleeding, or what will you do when there is minor hemorrhages or there is only minor warning hemorrhages? You what will you do? So usually whenever there is acute bleeding or severe bleeding, immediately you have to admit her to labor room. You have to secure two large IV bore cannula, especially 14 to 16 gauge, that is gray or blue. And then after you secure the cannula, you will send the blood for cross matching, CBC, and you will send for blood grouping and typing, and you will cross match. And for any case of placenta previa, at least 4 pints of PRBCs has to be cross matched, because sometimes there might be acute hemorrhage, and if you don't do the proper blood correction, she might land up in DIC and the maternal mortality. So that is why you have to admit her to labor room, secure two IV bore cannulas, and at least you have to, whenever there is acute episode of bleeding and you have seen that the patient has gone and lost much blood, you have to not you have to not just keep waiting and for blood. By the time the blood comes, you have to at least give RL and NS. So you have to give a total of 3.5 liters of IV fluids. So what you will give? Usually 2 liters of Hartmann solution. So the Hartmann solution should be given, plus at least 1.5 liters of colloid preparations have to be given. So this is how you prevent hypovolemia or you prevent hypovolemic shock. So prior to blood, so it takes at least for 20, 30 to 45 minutes for the blood to get cross-matched and to reach your labor room. So by that time, you have to vigorously correct her hypovolemia. Otherwise, she will go into decompensated shock. So that is why we have to at least infuse 3.5 liters of IV fluids. In that 2.2 liters, 2 liters will be Hartmann solution and 1.5 will be colloid preparations. And then you have to monitor her pulse, BP, respiratory rate, saturation, and we have to see how much bleeding she has. And you have to monitor all these vitals every 15 minutes. And we have to secure, we have to put a catheter and also see whether the urine output is adequate. So there should be at least 100 ml of urine output in 4 hours. And we have to do a clinical examination, take a detailed history. And of all this, you have to do everything simultaneously. So one person has to be taking history, the other person has to be doing examination. The one more person has to go and arrange for blood products. One person will have to document everything. So it is like a team effort. It is not like a single person can manage APH. So that's why you have to do all these simultaneously. And also we have to see the maternal and fetal well-being. So maternal, how will you see? You will see the pulse, you will see the BP, you will see saturation, you will see urine output and see whether everything is fine or not. How will you see whether there is fetal compromise or not? Especially the admission CTG should be done, and never do a vaginal examination in suspected case of placenta previa. And speculum also can be done after 48 hours once the bleeding stops, to rule out any cervical pathology. So if you want to rule out erosion or you want to rule out cervical polyp or cervical carcinoma, you can do once the bleeding settles. But if there is active bleeding, you cannot do all this. You have to shift the patient to OT and you can examine under anesthesia. So this is the best way to diagnose the condition immediately under anesthesia. It is not nice or it's not advisable to explore the bleeding in the labor room. So always shift her to OT, secure airway, breathing, circulation, and then under anesthesia you see a speculum examination. And if there is no placenta, you can also do a vaginal examination, or intraoperatively you can see the ultrasound also. And the woman should be given a clean diaper, and she has to ask whether she has been changing and she has further episodes of APH. And an urgent ultrasound has to be confirmed to see whether there is any low lying or placenta previa, and also to see the fetal well-being. So how do you manage? As I already told, administration of IV fluids, especially 3.5 liters, and in that 2 liters will be the crystalloid solutions, especially Hartmann solution, and 1.5 liters of colloids. And then you have to immediately cross match for blood, and you have to transfuse PRBCs, and you have to assess the renal function by input output chart. And because of hypovolemia, there might be decrease in renal blood flow, which decreases the urine output. So that's why you have to assess the renal function as well, and see at least if there are at least 100 ml of urine output in the last 4 hours. And usually in such patients who are hemodynamically not stable, to assess the intravascular status, we can do a central venous pressure by putting a central line, and you monitor the central venous pressure, and it should be more than 65 mm of Hg. And also simultaneously you have to do a fetal evaluation where you do a USG and NST, and then after you have ruled out the placenta previa, you can also do a per speculum examination. So there are two types of management. There is something called as expectant management, and there is something called as immediate delivery. So what is expectant management? So there is something called as McAfee's Johnson's regimen, which is an expectant line of management. So what are the prerequisites? The mother should be hemodynamically stable. The bleeding should have been stopped. The fetus should be in good condition. That is, there is no maternal comorbidities, or there is no maternal compromise or fetal compromise, and the woman should not be in labor, and all the facilities for cesarean, blood transfusion and anesthesia facilities should be readily available. So if there is some amount of bleeding and you have just admitted for evaluation and further follow, in that period of admission, if there is no bleeding, you can just try expectant management. But if there is repeated episodes of bleeding, you have to immediately take her up for cesarean section. So what are the prerequisites for active management? the gestational age is more than 37 years, if the fetal reassurance is not there, if the fetus is dead, if the bleeding is profuse, if the mother is unstable, and if the woman is in labor. So that time you cannot go for McAfee Johnson's. You have to deliver her by cesarean section. So always you remember that the APH you need not do only cesarean. Even vaginal delivery can be done, but you have to expedite the delivery by augmentative methods. So how do we do an expectant management? We allow the patient to take best bed rest. You monitor the bleeding episodes, and you monitor the maternal and fetal condition. And if there is any anemia, you have to correct the anemia in the antenatal period itself, because there is high chances of development of PPH in cases of placenta previa and placenta accreta. So that is why we have to monitor the mother and fetal conditions, correct the antenatal anemia, cross-match blood, and if the period of gestation is less than 34 weeks, give antenatal corticosteroids and plan for an elective cesarean between 36 to 37 weeks of gestation. And when are the situations where you discontinue the expectant management? If there is recurrent bleeding, if there is maternal or fetal compromise, if there is suspicion of FGR, or if the patient has reached term or ruptured membranes, and if she's going into labor, all these conditions are contraindications for McAfee Johnson's regimen. And you have to also remember that it is a tailored approach. So you have to also keep in mind whether the patient stays nearby the hospital, whether they have 24 hours hospital facility, like to access the hospital facility, whether they have all transportation facilities. So all these you have to ensure. And in the IP management, within 72 hours, if she has no bleeding episodes, you can discharge her, and you have to ask her to come weekly visits, and you have to terminate the pregnancy by 36 to 37 weeks. So what is the mode of delivery? The lower uterine segment section is cesarean section is the most common thing. But when the placenta is anterior, what happens? It might be sometimes you have to cut through the placenta, or you have to sweep the placenta, rupture the membranes, and deliver the baby. If it is posterior placenta, don't touch the placenta until it is delivered. So after the delivery of the baby, give 60 minutes time. If the placenta is not separating even after active management of third stage of labor, then you might have a need to explore in OT. Otherwise, you can just wait and watch for 30 minutes. And if there is profuse hemorrhage, you can put something called as purse string sutures or Cho sutures. So what is Cho sutures? It's approximation of the anterior and posterior uterine wall by sutures, and it is done in 4 different quadrants of the uterus. So this is called as the Cho's suture. Whenever there is uncontrollable hemorrhage, it is always better to go and do an internal iliac artery ligation. And if it does not suffice, you have to not take delayed decision. We have to go ahead for cesarean myomectomy also. And if there is any adherent placenta, you have to go for uterine artery embolization. So how this is the algorithm. So assess the amount of bleeding, the gestational age, the fetal condition, stabilize the patient, arrange the blood, and if there is expectant, if the mother is hemodynamically stable, bleeding has stopped, fetus is reassuring, the gestational age is 36 weeks, woman is not in labor, then you go for McAfee Johnson's regimen, that is bed rest, monitor the mother and fetus, correct antenatally, you correct anemia, give corticosteroids, give magnesium sulfate, and elective termination at 37 weeks of gestation. If there is less than that, if there is more than 37 weeks of gestation, if there is any intrauterine fetal demise, if the bleeding is profuse, if the hemodynamically, if the father is not stable, then you have to go for urgent delivery. You have to transfuse IV fluids and blood and take her up for cesarean section. So if she is in the primary health center, how do you refer her? You put 2 IV bore cannula, blood grouping cross matching has to be done, and oxygen should be given SOS. The woman should be transferred along with the hospital staff to the nearest functional center. And if the woman is diagnosed with previa, the deliveries in PHCs, the delivery should be conducted with 2 IV lines and active management of third stage of labor. And the labor should always be performed, and you should not be denying that. So what are the causes of maternal mortality? Mainly obstetric hemorrhage. That shock, if she goes into grade 4 shock, she cannot be revived back. especially when it is attached, when it is associated with attached placenta. And preterm delivery, which is a major cause for placenta previa, is also one of the major cause of perinatal death. So that is why we have to work out the balances between risk and management of continuation of pregnancy. So if the risk is less, you can continue the pregnancy, and you have to keep a watch and also advise her the the warning signs. So if she has any immediate bleeding, or if she has any profuse bleeding, or if she has any other symptom, she has to immediately report to the hospital. So can we continue with abruption?
Yes, ma'am.
Any doubts with placenta previa?
No, ma'am.
So what all you learnt about placenta previa? We understood the definition of placenta previa, the incidence of placenta previa, many etiological factors, what are the theories behind development of placenta previa, what are the risk factors, and how do you clinically assess, what are the symptoms, what are the signs, what are the classifications, and what are the ultrasound features, why TBS is better than TAS, and how do you manage placenta previa, whether you want to do a expectant management or you want to do a surgical management where you terminate the pregnancy. So these are the different uh, things you have to know about placenta previa. Now coming next to abruptio placenta. So what is abruption,
Premature
Bhargavi?
separation of the placenta from the uterus
Yeah.
before the delivery of the fetus.
Yes. So whenever there is premature separation, but what you have to mention is whenever there is premature separation of normally situated placenta. So whenever the placenta is in the upper segment, it is normally situated, but it is prematurely separating. So either partially or totally from its implantation site before delivery is called as placental abruption or placenta previa. Sorry, placenta abruption or abruptio placenta. So what is the incidence? It is around 0.5 to 1 cases in 200 deliveries. So that is around 2 people in 200 deliveries. And if the woman had prior history of abruption, there is chance of 12% increase in abruption. And who has history of two abruptions, the chance increases up to 50-fold. So what is the reason for abruption? It is mainly the chronic placental disease and abdominal trauma. So whenever there is placental disease and whenever there is hypoxia, especially in conditions like preeclampsia and HDP, there might be microthrombi formation and gets deposited in the placenta. So whenever it gets deposited in the placenta, what will happen? The blood flow will not go from the mother to the baby. So this will cause hypoxemia and at the level of the placenta, and it causes premature separation. And also because of inefficient flow of oxygen from the mother to the baby also might develop FGR, fetal distress, and sometimes it might also lead to stillbirth. So what are the pathophysiology? Mainly the genes and the environment. So what are the environmental factors? So maternal smoking, cocaine abuse. So all these will cause microthrombi formation. So that is why this, along with any genes or prior history of placenta abruption, all those will go and cause changes in the extracellular matrix, and they cause thrombosis and bleeding, which gives rise to inflammation. So this gives rise to in placental attachment and altered vascular pressure, and also it has mechanical defects and increased production. So because of all this, that's microthrombosis formation in the placental vasculature, which might cause the detachment of the normally situated placenta, which is nothing but placenta abruption. So, what happens whenever there is abnormal trophoblastic invasion or abnormal development of spiral arterioles, there is deciduitis, that is decidual necrosis, infection, inflammation, and bleeding. And because of all this, the thrombin is released into the circulation, and this might cause the life-threatening complication called as disseminated intravascular coagulation. So this is the main mechanism for chronic abruption. So what
Ma'am,
are
can you
the
show that slide once again? Can you show the previous slide?
there are
No,
genes, there are
the
environmental
mechanisms.
factors. So all these go and cause the coagulation and thrombosis at the level of the placenta. There is infection and inflammation, And all these leads to the deciduitis, vasculitis at the level of the placenta. And because of the hypoxia and ischemia at the placental bed, it tries to get detached. So this is the mechanism of action of abruptio placenta. So this causes decidual necrosis, inflammation, infarction, and bleeding. So whenever there is bleeding, it gets collected behind the placenta. So it causes retroplacental clots. Sometimes these retroplacental clots they seep into the myometrium and serosa, and there might be changes over the uterus, which is also called as a Covelier's uterus. And this thrombin can be released into the systemic circulation, which might initiate a DIC, and the mother might go into DIC, AKI, and shock. So that is why we have to be very careful, and we have to see whether there is any retroplacental, that is concealed type of abruption. So what are the different mechanisms through which the thrombin increases? So it is thrombin causes direct uterotonic effect. It enhances the actions of matrix metalloproteinases. It upregulates the apoptosis genes at the level of the placenta. It increases all the inflammatory cytokines. It triggers the coagulation cascade, and it initiates the functional withdrawal of the progesterone. So all these are different mechanisms through which the thrombin increase in placenta abruption occurs. So how do we diagnose abruption? Usually it is after 20 weeks of gestation. So there is premature separation, there is disruption of the fetoplacental vessels, damaged vessels cause bleeding, and it causes hematoma formation, which results in placental separation and destruction of the placenta. So if there is more than 50% separation of the placenta, the fetus might succumb. So whenever there is more than 50% separation, the fetus might die. So that is why small amount of retroplacental clots, 10 ml, 20 ml, there is no much significance. But if there is major amount of repeated episodes of APH, and then if there is any bleeding during labor, you have to suspect placenta previa, and you have to manage it accordingly. And also we have to see, so this hematoma results in placental separation and destruction of the placental tissue, and also there is loss of maternal and fetal surface area, and this results in IUGR and stillbirth. So what are the changes which occur? What are the mechanical events such as blunt trauma, sudden uterine decompression? All these might cause. So whenever there is sudden PPROM, whenever there is trauma to the womb, so all these might cause sudden separation of the placenta. So also even when there is abnormal development of spiral arterioles, especially in case of severe preeclampsia. So whenever there is severe preeclampsia, it's a systemic multi-system involvement where this the microthrombi will go and sit in the placenta. And once there is infarction and ischemia at the level of placenta, there is residual necrosis, inflammation and infarction and bleeding, and this causes separation of the placenta. And also this I already told, the use of thrombin. So how is the incidence of placental abruption? So usually it occurs 1 in 100. The range is around 1 in 80 to 1 in 250. One third of all the antepartum bleeding can be attributed to placenta previa alone, and it placental abruption alone, and it peaks in the third trimester because of the uh, increase uh, what to tell, pathology at the level of the placenta. Because of all these decidual necrosis and infarction, there might be separation of the placenta. So 40 to 60% of the abruptions occurs prior to 37 weeks of gestation. So how do you diagnose? We diagnose both by history and clinical presentation, and by severity. So when is acute? So whenever there is abruption, it is tense, tender. So there is painful bleeding. So that time we heard there is painless bleeding. But whenever there is acute overt abruption, when there is vaginal bleeding which is associated with pain abdomen and uterine contractions, it is called as abruption. You can diagnose abruption. And it might, whenever there is severe abruption, so if there is more than 50% of the abruption, if it leads to fetal death. So if there is more than 50% of placental tissue which is separated, it might lead to fetal death. So initially there might be uterine tenderness, tachysystole, FHR will be consistent with hypoxia and fetal death. So what happens whenever there is placental separation? There might be acute episode of bleeding. So this bleeding causes hypertension, tachycardia, and fetal heart rate problems. And even vaginal bleeding correlates poorly with the extent of placental separation and its potential for fetal compromise. So whenever there is more amount of APH, the fetal compromise is happening. The prognosis is bad. And concealed abruption occurs less than 10 to 20% of the cases. So, what are the different etiopathogenesis or what are the risk factors for placenta previa? So, what are the risk factors? Increased age and parity. Whenever the race of the woman is African American, whenever there is preeclampsia, so whenever preeclampsia or hypertension, they contribute to 50% of the cases of abruptio placenta. So whenever there is PPROM, there is sudden decompression of the uterus, which might cause separation of the normally situated placenta. And whenever there is multiple gestation, chronic cocaine use or smoking, these are also different risk factors. And obviously thrombophilias also have deposition or there is development of microthrombi which leads to abruption, and uterine leiomyoma, external traumas, and whenever there is iatrogenic injury like external cephalic version or chordocentesis, that time there is iatrogenic exposure. So that is why even in such cases we have to be aware of, and we have to also see if there is any recurrent episode. So if there is recurrent episodes, there is higher chance of recurrence even in present pregnancy. And even if there is short umbilical cord, the prognosis is bad. So these are the different uh, uh, risk factors or etiopathological factors, and these are the different odds ratio for development of abruptio placenta. So what is abruptio placenta? It is the delivery of the placenta within the separation of the normally situated placenta after the period of viability within 36 weeks of gestation. So that is called as abruptio placenta. The age of the and parity, usually it is more in multiparous women. And I already told you damaged endometrium and impaired decidualization and infection and inflammation at the level of decidua might cause premature separation of the placenta. And also abnormal vasculature also will cause. So cigarette smoking, cocaine abuse, trauma, PPROM, all these are risk factors for abruption. So I told you if there is one abruption, the recurrence is 12%. If there is two severe abruption, the recurrence ranges uh, changes from 12% to 50 fold. So there are two types of antepartum hemorrhage. One is concealed, the other one is revealed. So what is concealed? There is only retroplacental clots and the fundal height will be more than the period of gestation. The patient has tachycardia, tachypnea, but there is no active vaginal bleeding. So there is collection inside the uterus. So that is called as concealed hemorrhage. But most of the times the hemorrhage will be revealed. So this placental tissue once separated, the all hematoma gets escaped from the uterus. So this is called as, this trickling of blood is called as the revealed abruption. So there are some classifications which are put forward called Scher's classification, Page classification or Shatland's classification, out of which Scher and Page are more important. Bhargavi, read out this Scher's classification.
Scher's classification of abruption, grade 1 is mild, often retroplacental clot is identified at delivery. Grade 2 is tense tender abdomen and the fetus is alive. Grade 3A grade 3 has fetal demise, 3A has without coagulopathy, 3B has with coagulopathy. Out of which 3A is more common compared to 3B. In 2/3 cases it is 3A, in 1/3 it is 3B.
And 3B is only, it's associated with coagulopathy like DIC. So what are the grades of placenta previa according to Pate's classification? Again, there is 0, 1, 2 and 3. In 0, It is an asymptomatic case where there is just some lateroplacental clots after delivery of the placenta. Grade 1, there is mild symptoms. There is no vaginal bleeding or slight vaginal bleeding might be there. No signs of maternal distress. But grade 2, moderate symptoms, severe vaginal bleeding. Fetal heart rate might be present, but it might go into fetal distress. And because of fetal anemia, there is sinusoidal pattern in the CTG. And grade 3 is woody hard consistency of the uterus because of the concealed hemorrhage, and it might lead to the maternal shock and fetal heartbeat might be absent. In case of subtype B, in type A, it is present. So this is one of the classification called as Page's classification. So Page classification, Scher's classification, and something which is based on whether the bleeding is present or not. So there is concealed hemorrhage, there is revealed hemorrhage, and there is mixed hemorrhage. So these are the types of abruptio placenta. So what is Burnett-Lunen's classification? If there is mild retroplacental clots less than 30 ml, if it is moderate to severe, the retroplacental clots weigh between 30 to 150, and if it is more than 150, we call it as severe Boren Boren-Lunen's classification. So this is a person who introduced Cavalier uterus. So he is a person named as Cavalier. So he's a French physician. So he described something called as the Cavalier's uterus or uteroplacental apoplexy.
Apoplexy.
So uteroplacental apoplexy is a rare fatal complication of abruption. The blood might get dissected into the myometrium and serosa, and it can appear like this. So this is the Cavalier uterus. So there is constant pain which is hard on palpation, and the diagnosis can be made on visual progression of the uterus, visual inspection of the uterus in the intraoperative period, and it might lead to atonic uterus and later PPH. There is no need for cesarean hysterectomy if you find this picture. If this picture is there, you just put a drain and you have to manage accordingly by medical management and not surgical management. And what are the clinical manifestations? If there is temporal nature of abruption, if it's acute abruption or chronic abruption, if it is concealed or revealed, and if the severity is mild to moderate or very severe. And in acute hemorrhage or acute abruption, the chances of vaginal bleeding, pain abdomen. So there is tense. So what are the characteristics of bleeding? There is tense, tender, and tonically contracted uterus. So this is also given in Datta. So tense, tender, tonically contracted uterus is important. Symptoms, signs, there is uterine tenderness, abdominal pain, uterine contractions, and sometimes there is no relaxation in between. There is continuous contractions. So there is hypoxia. Sometimes it leads to fetal tachysystole and abnormal FHR pattern. Also sometimes lead to fetal death. So that is why chronic uh, abruption, usually it's insidious. It's associated with ischemic placental disease, especially preeclampsia. So 50% of the preeclampsia women attribute to abruption. So out of 100 abruption women, 50% are attributed to severe preeclampsia. And what are the signs? There is FGR, there is oligohydramnios, there is preterm labor, there is PPROM, and there is preeclampsia. So all these are the implications of chronic abruption. So what are the complications? In maternal, anemia, infection control, maternal shock, acute tubular necrosis, DIC, PPH, postpartum depression, and complications of blood transfusion. In fetal, there might be hypoxia, SG or FGR baby due to chronic hypoxia, which might also lead to prematurity and fetal death. So what are the differential diagnosis? So differential diagnosis for abruption is placenta previa, true labor pain, uterine rupture, and vasa previa. So these are the four things you have to keep in mind. So how do we differentiate between placenta previa and abruption? Bhargavi, can you read out this?
Yes, ma'am. Placenta previa, the nature of the bleed is painless, apparently causeless and recurrent. Whereas abruptio placenta is painful and often attributed to preeclampsia, trauma, and it is continuous. In previa, the bleeding is always revealed, whereas abruptio placenta can be revealed, concealed, or a mixed variety. Character of blood in placenta previa is bright red. In abruptio, it is dark red. General condition and anemia in placenta previa, it will be proportionate to the visible blood loss, but in abruptio, because of the concealed variety, it can be disproportionate. We may underestimate the bleeding because per vaginally the bleeding may not be as much. Features of preeclampsia, it is not relevant in case of placenta previa, whereas in abruptio placenta, it can be there in one-third cases. Examination, height of the uterus is proportionate to the height of the gestational age in placenta previa, whereas it can be enlarged in concealed type of abruption. Feel of the uterus is soft and relaxed in previa, whereas it can be tense, tender, and rigid in abruption. Malpresentation is common in placenta previa and the head is high floating, whereas it is unrelated and the head may be engaged in case of abruptio placenta. Fetal heart sound may be present, usually present in previa, and it is usually absent, especially in concealed type in case of abruptio placenta. On ultrasound, in previa, the placenta is usually lower segment. In abruptio, it is in the upper segment. Vaginal examination, placenta is felt on the lower segment in placenta previa. In abruptio, it's not felt in the lower segment. Blood clot should not be confused with placenta.
Yeah. So these are the different changes with respect to clinical features, the examination. So in examination, what is important? The placenta, whenever there is retroplacental clots and there is concealed type of abruption, the uterine size might be more than the period of gestation. So this is also one of the differential for it. And always you have to remember the placental previa is painless bleeding. But whenever there is painful bleeding, you have to remember three T's: tense, tender, and tonically contracted uterus. So tense, tonically contracted uterus, which is wood consistency. So you will, if you touch the uterus, it will be as hard as the wood, the tree bark. So that is why it is called as woody in consistency. It is also called as ignis in consistency. So ignis means it is that hard feeling. So that will be there in abruption, and there might not be any episodes of relaxation. So this might lead to fetal demise also. That is why in abruption you have to expedite the delivery. So how will you diagnose? Mainly by clinical presentations, symptoms and signs, radiological diagnosis, laboratory assessment, and fetal assessment. So diagnosis mainly is the clinical diagnosis. So abruption is mainly a clinical diagnosis because sometimes you don't have time to send her for a scan. So what are the findings? There might be vaginal bleeding, uterine contractions, there might be associated with pain abdomen, and trauma also should be kept in mind. And we have bleeding can be underestimated because it might be concealed because of the retroplacental clots, and it has a typical abruption of contraction is high frequency and low amplitude, and it has continuous effort on stimulation of uh, going into labor, true labor pain. So how do you do a scan? So usually you can do a scan. It improves the detection rates by 2%. Early hemorrhage is slightly hyperechoic, but resolving hematomas are hypoechoic. So this acute hemorrhage might be interpreted as homogeneous thickened placenta or any fibroid because of all the blood collection in the lower uterine segment. So this you can see the beautiful picture where the placenta has been separated from the uterine wall and there is collection of the blood. So this is the presence of retroplacental clots. So this hyperechoic or isoechoic resolving hematoma, and these hematomas usually take about 2 weeks to resolve. So we have to identify three predominant locations of placental abruption. So there is something called as subchorionic, retroplacental, and preplacental. So what is subchorionic? It is between the placenta and the fetal membranes. What is retroplacental? Just behind the placenta, that is between the placenta and the myometrium. And what is preplacental? It is in front, that is placenta, between the placenta and the amniotic fluid. So these are the types of placental abruption for where the hematomas are present. So usually retroplacental hematoma have worst prognosis because the chances of bleeding might be underestimated. So large retroplacental hemorrhages associated with more than 50% of greater fetal morbidity. So if there is large retroplacental hematoma, there might be chronic hypoxia and fetal mortality. And small size usually does not cause mortality, only in 10% it causes. So MRI can be done. And there are some important investigations that these are the abnormal serum markers which are early in pregnancy, which might act like one predictor of placental abruption. So whenever if the alpha fetoprotein and beta HCG are more and papa is less, these are the chances where the serum markers tell that there is increased chances of abruption in this pregnancy. So once the placenta is delivered, we can see the depression of the placental cervix due to the pressure of the retroplacental hematoma, and histologically we can see villus stroma edematous, degeneration of the syncytiotrophoblasts, scattered neutrophils with villus agglutination. Chronically, there might be deciduitis, villitis, necrosis, vasculopathy, infarction, intervillus thrombosis, villus maldevelopment. And because of all this, because of this separation, all these things might be found on gross and HPE examination. Next, very important is management. So, how do we manage? We have to start with ABC, airway, breathing, and circulation. Secure two IV bore cannula, especially large cannula, 14 to 16 gauge. Type and cross match blood for possible transfusion, blood grouping and RH typing, and send all relevant investigations. And then follow up with an APH chart. How many episodes of bleeding? What is her pulse, BP, saturation, urine output? All these are important. And if she is less than 34 weeks, steroids has to be done. And if she is more than 37 weeks, we have to immediately expedite the delivery. And there is some classification called as the Benedict's classification based on the blood loss. So if there is less than 15% of blood loss, it's called as class 1, 15 to 30, class 2, 30 to 40% of the total blood volume if it is lost, it is class 3, and more than 40% it is class 4. So the pulse in the first two categories it's around 100, but in the second category it is more than 120. In the fourth category it is more than 140. Pulse BP will be normal in the first two classes and it will decrease in the last two classes. Capillary refill time also keeps on increasing. The respiratory rate also will be between 14 to 20 in class 1, 20 to 30 in class 2, 30 to 40 in class 3, and more than 40 in class 4. And more than everything, the mental status of the mother is important. And if she is slightly anxious, she belongs to stage 1. If she is mildly anxious, stage 2. If she is confused, it is stage 3. If she is already lethargic and she is not oriented to time, place, and person, it is stage 4. So based on class of the hemorrhage, we have to monitor. So whenever there is placental abruption with acute hemorrhage, IV access and resuscitation, laboratory tests, and it is a multidisciplinary approach. And class 1, what you will do? You will transfuse, actively cross-match at least 2 units of PRBC, and 6 to 8 hourly you will check for the blood investigations. Class 2, you will give PRBC, you will monitor the vitals, and if you see whether she is responding properly or not. Class 3 and class 4, you have to manage very vigorously because she might go into a decompensated shock and you might not be able to revive her back, and she might go into DIC also. That is why along with the PRBC, we have to also give other blood products, especially FFP and platelets in the ratio of 1:1:1, and the we have to monitor the response for these therapies, and we have to send the investigations every 4 to 6 hourly. And fetal assessment should be done. And if the CTG is category 1 or 2, you will induce or do an early ARM. If it is an IUFD also, you will induce and do an early ARM. If it is category 3, you will just go and do a cesarean section. So if the cervix is not favorable and if you think it requires more time, if there is maternal compromise or if there is fetal compromise, immediately you will go and do a cesarean section. So these are the different case scenarios. So if there is unstable mother, the vaginal delivery is not imminent, go for a cesarean section. If there is non-reassuring FHR, go and do a cesarean section. If there is unstable mother with dead fetus, you at least expedite the process of delivery. That is, you at least do a ARM and augment with Synto. If she does not get progress, then again take her up for cesarean section. If there is stable mother with a dead fetus, then you can do a vaginal delivery. If both baby and mother are stable, if the period of gestation is less than 34 weeks, you will conservatively manage, give antenatal corticosteroids and tocolysis. If more than 34 weeks, you have to conduct the delivery and terminate the pregnancy. So the termination, the mode and timing depends upon the maternal and fetal condition. So if the maternal and fetal condition is everything normal, you can push till 34 to 37 weeks of gestation. If the mother is going into DIC or if she's going into shock, if the baby's heart rate is not reassuring, then you cannot waste time. You have to immediately take her up for cesarean section.
Ma'am, is there any entity called indeterminate APH? Is there? Because we had a few cases in which the patients came to us with spotting PV, recurrent spotting PV at 32 to 34 weeks, and there was no cause of local cause of bleeding. There was no trauma, and ultrasound was done. The placenta was in the fundus in some of the cases. Despite that, they had bouts of bleeding, and in some of the running notes, I had seen some SR document it as query indeterminate APH.
That is the undetermined origin. So what
Okay.
I mentioned in the first slide. So sometimes there might be no cause for APH. So whenever you're not able to see the cause, it might be undetermined or indeterminate APH.
Okay. How could that happen, ma'am? Placenta is well above. There is no local
Sometimes
cause.
there might be small amount of bleeding which might not get collected inside. So it could be like a slow abruption. So there
Okay.
might be small amount of trickling which is occurring, and there is no collection as such in the retroplacental area. So this trickling and you have augmented and delivered the patient. So that means there is no obvious bleeding, but there is some amount of trickling. So it could be an like slowly evolving abruption. And there is something called as vasa previa. So what is vasa previa? Whenever the fetal blood vessels traverse the lower uterine segment in advance of the presenting part, unsupported by either the umbilical cord or the placental tissue. So these fetal blood vessels are just overlying the internal os. So whenever they are overlying the internal os, whenever the membranes get ruptured, these will bleed torrentially and it might the baby might succumb. So whenever there are two types of vasa previa. There is type 1 vasa previa and type 2 vasa previa. So whenever there is velamentous cord insertion, at that time, whenever the vessels are coming and they are overlying the internal loss, then there is also, this is called as type 1. So this is because of the velamentous insertion of the umbilical cord. So if this is the placenta, if this is the umbilical cord, sometimes the blood vessels are traversing outside the umbilical cord overlying the internal os. So this is type 1. So what is type 2? There is a big placenta and there is a succensurate lobe and there are some vessels which are traversing between the two placentas. So if there's one major placenta and there's a small succensurate lobe and if the vessels are traversing between these two and these vessels are overlying the internal os, and then also it is called as vasa previa. It is a rare condition, 1 in 2500 to 5000, and it might usually cause fetal blood loss because of spontaneous rupture of membranes or artificial rupture of membranes. So immediately after rupture of membranes, there is torrential bleeding, which is also accompanied by fetal heart rate changes, fetal decelerations and bradycardia. So what are the risk factors? Velamental insertion, when the vessels are crossing between the lobes in sexensurate and bilobate placentas, and whenever there is placenta previa, or if there is a conception with ARTs. So antenatal diagnosis of vasa previa is of utmost importance because sometimes if you have not diagnosed antenatally and in the process of labor, if you just rupture the membranes, the baby might succumb. So that is why the prenatal diagnosis is made up with high accuracy with ultrasound by sensitivity of 100% and specificity of 99 to 99.8%. So we can use transvaginal color Doppler also. If it is unrecognized before the onset of labor, the fetal morbidity is very high, as high as 22 to 100%. So to improve the prenatal diagnosis, we have to do a prenatal ultrasound and we have to see the umbilical insertion site. So where the cord is inserted. So is it velamentous or not? And if it is velamentous, we have to see if these vessels are just present above the internal os. So this gives us the gold standard for identifying vasa previa in the antenatal period. So you can see here, so this is the cervix. So this is the vessels which are, this is the placenta. So the vessels are outside the placenta overlying the internal os. So this is a beautiful picture where the color Doppler is showing the vasa previa. Are you understanding?
Yes, ma'am. But how different is it from cord prolapse?
No, the cord prolapse will not be like this. So cord prolapse, whenever it is coming, it is coming down like this. The entire cord will be coming down. But here only the vessels are coming. So this is the cervix. So this is the placenta. So usually when you see the cord, you will be able to see the cord. You can see the vessels which are running inside the cord. But this is not like that. The vessels will be freely. It is not
Okay.
having that cord, like
Bottom
you
still.
will be able to easily make out the cord, which is
Okay.
like a pipe. But in this, the vessels are freely, they are dispersed. They are not that organized into the cord. So cord
Okay.
usually you can make out. So if these are not like that, these are the free vessels which are present overlying the os. So that's why whenever you're focusing the mm, cervix and placenta, you have to always put a Doppler and see. So to see, to rule out vasa previa. So this is also very important when you're doing a vaginal ultrasound to rule out vasa previa. So what is the management of choice? So we have to do an elective cesarean between 35 to 36 weeks of gestation. And sometimes others prefer to do 37 to 38, but always it is better to do as earlier, because if she bleeds, the fetus might go into acute anemia and die also. So that is why we have to always do elective cesarean section prior to the onset of labor. So you should not allow the patient to go into labor. Once she's gone into labor, you have to immediately do a cesarean section. So you can give corticosteroids, admit her from 30 to 32 weeks, and then you can deliver her by 35 to 36 weeks of gestation. So management, whenever there is continuous electronic fetal heart monitoring and by rapid biochemical test of hemoglobin can be considered. And if there's any one of this as abnormal, you have to do a cesarean section. If it is not diagnosed in the antenatal period, if there is sudden bout of bleeding, and if the above things are abnormal, immediately take her up for cesarean section. And physicians must be vigilant that whenever amniotomy is performed, as not all the cases of vasa previa are diagnosed antenatally. So once you rupture the membranes, if there is torrential bleeding, that is the diagnostic criterion for vasa previa. So if there is any suspicion, we have to go for an immediate delivery to avoid fetal shock or demise. So whenever there is APH or whenever there is increased amount of bleeding, they might go into something called as disseminated intravascular coagulation or consumptive coagulopathy. So abruption is the most important cause which causes DIC in pregnancy. So what is the pathophysiology behind this? So whenever there is abruption, there is release of tissue thromboplastin from that retained blood clot. So this tissue thromboplastin enters the systemic circulation and it causes widespread endothelial damage and microthrombi formation in the entire vascular tree in the systemic circulation. So whenever these microthrombi are forming, there is microcoagulation, there is consumption of all the coagulation factors leading to consumptive coagulopathy. So this leads to bleeding and clotting. So there is excessive bleeding and there is clotting. Bleeding and clotting, it's like a vicious cycle. So there is bleeding in abruption, which is not controlled, might lead to DIC. So, what are the clinical manifestations? There might be cannula site ecchymosis, there might be purpura, there might be petechiae, there might be subcutaneous hematoma. So, all these might form. And if you have done a cesarean section, there might be surgical or traumatic wound bleeding, also bleeding from the venipuncture sites, and the patient might go into shock or acidosis. So, what are the laboratory investigations which show that there is DIC? Obviously, in peripheral smear, it shows microangiopathic hemolytic anemia, thrombocytopenia, leukocytosis, and schistocytes. So, schistocytes are those helmet-like cells. Because they pass through the circulation, the RBCs lose their shape, and because of that they are called as schistocytes, and they are hemolyzed, and there is increase in LDH also, and platelet count may fall below 20,000. Prothrombin time will increase, partial thromboplastin time will increase, fibrinogen level will decrease, and D dimer also might increase. So all these are laboratory tests and DIC. So how do we manage? We always correct the underlying problem. ABC you have to do transfusion of IV fluids and blood products, and we have to monitor the vitals and correct hypofibrinogenemia. And if there is active bleeding, we can use fibrinogen also as a adjunctive management for control of APH. So how do we use fibrinogen replacement therapy? So whenever there is hypofibrinogenemia, that is less than 100 mg per dl, what we have to do? We have to start giving fibrinogen by giving FFPs. So one FFP increases the fibrinogen by 10 mg per dl. So FFP or cryoprecipitate, all this can be given, and this can be given by a formula called as the target fibrinogen minus the measured fibrinogen divided by correction factor. So 1.7 to 1.8. So based on this, you have to decide how many pins or how many units of FFP and cryoprecipitate is needed based on the fibrinogen level. So usually the management of DIC depends on its severity, the gestational age, and the maternal and fetal status. So ABC, secure IV lines, cross match, and follow up with APH card, steroids, and you have to deliver her as soon as possible. And you have to monitor the fetus and monitor the mother, and you have to also communicate with the neonatal personnel. So neonatal outcome, there might be increased chance of perinatal mortality and morbidity. You can cause hypoxia induced periventricular leukomalacia, and sometimes it will cause SIDS also, sudden infant death syndrome, where there is also chronic hypoxia, and if there is any FGR, they might succumb immediately or within the womb itself. So these are the principles to follow whenever there is bleeding during pregnancy. So this is again from the GTG. So whenever there is massive hemorrhage, that is more than 1000 ml of blood loss. So what all you have to do, it's a multidisciplinary team approach. So first call for help, call for all the anesthetist, pediatrician, everyone, and ABC. So assess the airway, breathing, give high oxygen and oxygen by mask, so that is 10 to 15 liters. Circulation established to 14 gauge IV lines. 20 ml of blood is sent for cross matching, full blood count, blood grouping and typing, coagulation, RFT, LFT, and cross match at least 4 units of blood. And D, assess the fetus and decide on the delivery. So this ABCD approach you have to follow. So what are the 4 pillars of management? You have to communicate between all multidisciplinary team, resuscitation, that is ABC, monitoring and all the investigations, and we have to arrest bleeding by delivery of the fetus. So how do you give a fluid? So whenever there is no clinical shock, we give Cummins crystalloid solution. If there is massive hemorrhage, then airway, breathing, circulation, oxygen, intravenous axis, left lateral tilt, and we have to start with IV fluids and at least 3.5 of warmed crystalloid Hartmann solution, that is 2 liters, and colloid, that is 1.5 liters. And we have to achieve warmed fluid should be given to prevent hypothermia, and also some fluid therapies like crystalloids, colloids, till blood is come has to be given. And for every 4 FFPs, we have to give 4 FFPs have to be given for every 6 units of red cells. So this is very important. So 4 units of FFP have to be given for every 6 units of blood cells. And if prothrombin and APTT are elevated, then you give even more. And if the platelet is less than 50,000, give give platelet concentrates also. And if fibrinogen is less than 1 gram, give cryoprecipitate also. So by giving, you have to follow a massive transfusion protocol, and you have to resuscitate the mother actively by doing airway breathing and circulation. So, what is your main therapeutic goal after a major blood loss? Hemoglobin should be more than 8 gram percent, platelet count more than 75,000, thrombin and prothrombin time should be less than 1.5 into mean control, and the fibrinogen should be more than 1 gram. So, I will repeat, hemoglobin more than 8 gram percent, the platelet count more than 75,000, PT, APTT less than 1.5, and fibrinogen more than 1 gram per liter. So this is about how to manage when the mother comes in acute bleeding. So what all we learned today? We learned the definition of antepartum hemorrhage. What are the causes of antepartum hemorrhage, especially the placental causes, non-placental causes, and systemic causes. Under placenta previa, we understood what is placenta previa, what is the types of placenta previa 1 to 4, what is type A, what is type B, what is dangerous placenta previa, what is the incidence, what is the migration theory, and when the migration is less likely to occur, what is the etiopathogenesis, what are the multiple risk factors for placenta previa, and how do you evaluate, what is the gold standard, especially ultrasound should be done and then it should be repeated at 32. If still persistent, repeat at 36. And if still persistent and asymptomatic, deliver by 36 to 37 weeks. If she is symptomatic, give course of corticosteroids and deliver by 34 to 36 weeks of gestation. And if she has no major bleeding or there is no severe bleeding, you can go and follow a McAfee Johnson's formula. And you have to see if the mother is transport facility is available, whether the in-house of delivery has 24 into blood transfusion, anesthetist, pediatrics, everyone, and she has to be compliant to bed rest at home, and she has to have supportive family also. So all this criteria, if they satisfy, you can send her home for McAfee Johnson's regimen, and you have to ask her to come with the weekly. But if there is any maternal or fetal compromise, you have to deliver immediately based on whether you want to do a vaginal delivery. And but most of the time, since placenta previa, you have to do a cesarean section. So that was about placenta previa. Abruption, you have to know what is abruption, what are the types of abruption, what are the classification, what is the incidence, what is the risk factors, and how do you evaluate, and what are the signs, symptoms, and laboratory investigations, and what is the chances of DIC, how to manage DIC, and also you have to know the differences between placenta previa and abruptio placenta. And last but not the least, you have to know about vasa previa, its definition, the types, type A and type B, and how do you do an antenatal diagnosis, and how will you deliver her. So by 32 weeks you have to admit her, and by 34 weeks you have to deliver, because you have to deliver her before the onset of true labor pain. Otherwise she might bleed and fetal distress might occur. So this was about placenta previa, abruption, and vasa previa. Do you have any doubts
Ma'am, could you repeat type A, type B of asaprevia?
of vasa previa? Type A is whenever there is velamentous insertion, the fetal vessels are overlying the internal os. So that is type A of vasa previa. What is type B? Whenever there is one big placenta, one small placenta, and the vessels are traversing between these two, either a succinsurate lobe or a bilobate placenta. So these vessels are present between the two placental quadrilaterals. So whenever these vessels are overlying the internal os also, they might get ruptured when you do a artificial rupture of membranes, or there is spontaneous rupture of membranes. So in both type A and type B, there is acute fetal blood loss which might lead to fetal bradycardia and death. So that is why you have to do a elective cesarean section prior to labor. And also, whenever the mother comes with acute bleeding, you have to know what are the important things: ABC, cross matching, IV fluids, that is at least 3.5, out of which 2 is Hartmann's, 1.5 is colloids. Then you have to replace PRBCs, and for every 4 PRBCs, you have to give FFPs, and you have to give platelets if the platelet count is less than 50,000. And your optimal achievement of blood investigation should be HB at least should be 8 gram percent. The PTI APTT should be less than 1.5. Platelet should be more than 75,000, and fibrinogen should be more than 1 gram per liter. So all these are target lab values when you're doing a correction for DIC or whatever, whenever there is acute bleeding during pregnancy. So this is about antepartum hemorrhage. So I have not covered placenta accreta spectrum, that I will do a free YouTube video and I will upload. Okay, so that you can follow that also.
Okay.
So that was about APH. The sources you have to study is, it is good in Williams and it is also good in Gabe. And I will share you GTG guideline of placenta previa and abruption. So you can follow those. And also there is FIGO consensus for placenta previa and management. I will be sharing you that also. So these are the sources for study. So if you have any doubts, you can post it on group. Okay. Any doubts?
No, ma'am.
Okay. Thank you. Happy
Thank you.
studying. Good night.